Well, good evening, everyone, and welcome to the SCAI 2021 Scientific Sessions Late-Breaking Clinical Science Roundtable Discussion, Part 2. My name is Kirk Garrett. I'm the Medical Director for the Center for Heart and Vascular Health at Christiana Care in Wilmington, Delaware. I'm also past president of SCAI and currently the chair of SCAI Communications Committee. It's my honor to sit alongside Dr. Steve Bailey, my good friend and a fellow SCAI past president, who also happens to be editor-in-chief of SCAI's journal, Catheterization and Cardiovascular Interventions. Our job tonight is to bring forward our panel of experts and opinion formers to interpret some of the late-breaking clinical science that you've heard in the SCAI 2021 virtual sessions on days 2 and 3. Our panel of presenters and experts are drawn from the best of the best off the Communications Committee and include Dr. Dennis Kim from Children's Sibley Heart Hospital in Atlanta. Welcome, Dennis. We also have Dr. Creighton Mavramatis, who's also from Atlanta, from Emory University. Creighton, glad you could join us. And finally, Dr. Lawai Tabaza, who's from Einstein Medical Center in Philadelphia. We're so happy all of you could join Steve and me to hear summaries of the science and the presentations made, and we're looking forward to how you interpret these important breakthrough presentations and how they will impact your practices. So we're going to start off looking at the congenital work that was presented. The first discussion is going to be around the presentation on the Harmony transcatheter pulmonary valve. There is a presentation on the 1-year outcomes from the pivotal trial and 30-day outcomes from a continued access study. Dr. Kim is going to review the data for us and then tell us what we should think of it. Dennis, the podium is yours.
Thanks so much, Kirk. The Harmony transcatheter pulmonary valve trial is an important one in our area of congenital heart disease because, unlike in other parts of the cardiovascular space, these kinds of devices don't come that often to the congenital realm. In the past, we have had probably the most impact in transcatheter pulmonary valve implantation. And in fact, the very first transcatheter valve implant actually occurred in the pulmonary position just a few months before the aortic position. And so, but we knew that that only covered a very small portion of potential patients with RVOT abnormalities, and maybe only would cover about 20% just because of the heterogeneity of the reconstructed RVOT. And so the Harmony transcatheter system was developed to be used in very large right ventricular outflow tracts to serve as both a size reducer as well as a valve replacement. And so the Harmony valve by Medtronic has undergone an initial study, and they're reporting their 1-year outcomes from their pivotal trial, as well as their newer continued access study, which started not long ago, but they're reporting their 30-day outcomes. And so this trial involves 20 participating sites in the United States, Canada, and Japan. And that's kind of interesting in that in the past, for congenital device trials, the Japanese market has not necessarily been one that we have been able to collaborate with, and so that's been a welcome addition. So this followed a total of 68 patients in both the pivotal trial and the continued access study. Interestingly, the patient populations, or at least the valve types that were implanted, are a bit different between the pivotal and continued access. The original Harmony valve was on the smaller side, and in fact, with the early feasibility trial, only 7% of screened patients actually were able to have implants with that early feasibility trial. And so Medtronic then came forward with a larger and shorter valve system, the TPV-25. And so you can see with the pivotal trial that about 2/3 were the smaller valve, because that was what was available initially. But clearly, these implant zones require larger valves. And so you can see that in the continued access trial, that is very much tilted towards the larger and shorter 25 millimeter system. And so it followed these patients both to 1 year as well as to 6 months. And you can see the follow-up durations below there. Go to the next slide. Kim, do you mind advancing just to the next slide? Okay, so as is expected, the primary problem with people with with large RVOTs is one, not of stenosis, but of pulmonary regurgitation. And in the previous slide that just went by, we saw that the vast preponderance was for significant pulmonary regurgitation, which was remedied by the valve system that was studied. Now, in looking at clinical outcomes through 1 year, obviously, mostly these are the pivotal trial patients. Really, the complications have been very rare. One, brachial plexus injury overall. Mostly what occurred were the development of some ventricular arrhythmias, which is actually not necessarily that unexpected considering where these valve systems are placed. They're placed from the main pulmonary artery, sometimes through the native pulmonary valve annulus, and the inflow parts of these large outflow tract reducers may engage the RVOT and cause a little bit of temporary irritation. Over time, these arrhythmias typically have resolved and have not been a continuing issue for these patients. Is there one more slide, Kim? All right, so in summary, the data presented reflect an update from the previous report, including their early feasibility trials, as well as the more recent continued access patients. There were no explants, endocarditis, stent fractures, thrombosis of the valve system, and obviously no death. And the great majority of patients, essentially almost universally, had none or trace pulmonary regurgitation at follow-up visits. So this patient population will be followed through the next 10 years. FDA approval was granted at the end of March, so very recently. And this really reflects a type of valve system for the right ventricular outflow tract that is going to be a true game changer in the congenital space, so particularly for those adult congenital patients who may have a hostile chest for surgical reentry due to multiple previous sternotomy or multiple comorbidities that may make them very poor surgical candidates.
That's terrific, Dennis. Thanks for the summary. One thing that strikes me right away is, we're in the adult world, we're accustomed to seeing trials for something like a valve implant involve thousands of patients. And I'm impressed that FDA was satisfied with a modest number of patients here, recognizing it's a much less common ailment, of course. So you described this as a real step forward for congenital heart disease management. Give us a sense on a 1 to 10 scale. How much of a game changer is this for the management of these kids?
Well, I would say that in terms of this particular patient population, I would put this at probably a 7. I think that maybe even a 9 in the more advanced age adult congenital patient who really has no other options and who are developing right ventricular dysfunction, which we know can beget left ventricular dysfunction in these patients, which are typically tetralogy of Fallot patients, and then develop the initiation of significant tricuspid regurgitation due to right ventricular dilation. And yeah, that's a very a good point in terms of patient numbers. This is actually, not very large trial at all. I think that these are kind of the numbers that we have to work with. I must actually sort of applaud the regulatory processes in this country as they have been developing in terms of allowing these kinds of devices to move forward, both by using data from other trials. Also, there's been a initiative called Harmonization by Doing, by incorporating the Japanese experience in terms of trying to figure out the overall capabilities and potential problems of these new cardiac devices we have for the congenital space.
So Dennis, I like you, I'm excited about this. I do adult congenital heart disease and do see those patients you referred to. And not having to prepare that RVOT, not having to size down with stents is clearly a technically important advance in terms of simplifying the procedure. What I was most interested in actually was the absence of stent fracture and even an absence of endocarditis, both of which have been, concerning limitations in prior devices. And you might comment on why you think those two, at least at a year, are much less than we would have expected. I mean, a 10%, 12% range would have been what we thought might have been.
Yeah, that's a great point, because we know that the RVOT and the main pulmonary artery in these patients are very dynamic. There's torsion as well as shortening throughout the cardiac cycle. The absence of stent fracture is actually, to be honest, maybe a little bit surprising. I think that the properties of the nitinol that they're using for this particular stent frame system is a little bit different than what we've seen in some other cardiac devices. And so that may be part of it. Unlike the Melody valve, which is also made by Medtronic, this is not a bovine jugular venous valve within it, and this is a bovine pericardial valve, or porcine pericardial valve. And so that may have some influence on the endocarditis profile, which we have been investigating with the Melody system, as well as with the Contegra surgical system.
Yeah, I think both of those are additional advances that are welcomed in this space.
For sure.
Awesome. So that's great. And FDA has given this clearance, so it's available to American laboratories currently. Is that right?
Yeah, the Medtronic is going through sort of a rollout that will involve a second wave of continued access patients, and they are opening up to probably, I think, around maybe 15 or 20 centers. Obviously with technology this new, with a device that doesn't resemble anything else that currently is out there commercially, there's a fair amount of training that goes into being able to place one of these valves. And so I think that they are doing their due diligence and want to take the appropriate steps and make sure that the next wave of patients that will be occurring outside of the initial implant centers, will be able to achieve the same safety and success profiles.
That's terrific, Dennis. Thank you. I'm going to ask you now to pivot from the pulmonary valve to sinus venosus ASDs. There was a great presentation on the international experience of the 10 Zig covered CP stent correction of the sinus venosus ASD type. And I wonder if you can walk us through what was found and give us your thoughts about what we should make of this.
So this is actually representative of what the typical experience is in congenital cardiology. It's not a device-related trial. It's the use of products off-label to create creative new MacGyver-type solutions to issues that we deal with. And historically, the sinus venosus ASD, which is atrial septal defect in the upper part of the atrial septum, has thought to be not to be amenable to transcatheter repair, primarily due to the fact that it's not so much of an absence of the atrial septum, but it's an absence of the wall near the right-sided pulmonary veins, and which results in anomalous pulmonary venous drainage rightward of the plane of the atrial septum. And so the typical secundum ASD devices that we use require sealing along all of the edges, and there really is not that extra edge in the sinus venosus atrial septal defect, which allows purchase of the current Omplots or Gore devices in that area. And so Dr. Rosenthal, who has probably the largest experience of transcatheter correction of this defect, has looked into this issue with about 12 other centers throughout the world about the overall experience at covered stent correction. And so the idea is basically to make a funnel coming from the superior vena cava and expand the funnel so the lower part of the covered stent then creates a seal against the atrial septum. And so this involved a total of 75 patients, and these are typically people who have reached their full growth potential. This is not something that we have considered so much in the younger patient who would require a stent redilation with growth and such. Of those 75 patients, there were 72 successful implants. There were 2 that embolized requiring surgery, and 1 that resulted in pulmonary vein occlusion, which also required surgery. And one of the things about this study was that it really highlighted the utility of advanced 3-dimensional imaging in the pre-procedural evaluation for this kind of procedure. There have been various reports of using 3D models beforehand, doing virtual models, even reports of using holographic imaging to kind of get 360 spin, within the heart that you're looking at exactly where the pulmonary venous pathway and such is coming. And so, so this is really a testament to how our advances in the catheterization world also are possible due to more advanced imaging. And so these series of images show one of the issues that they had to deal with, and this is the placement of the covered stent from the superior vena cava below the level of the innominate vein and telescoping it down into the atrium. And the SVC being a relatively thin structure, there is a fair amount of compliance to it, and so you can see in that second picture from the left that the stent system had moved downwards. They're able to push it back up and anchor another stent to anchor the cephalad portion of the stent. And these are the things that kind of came along with their learning experience through this. Interestingly, Dr. Rosenthal is one of the very few people in the congenital community, and probably also in the adult community, who's both a interventional cardiologist as well as a electrophysiologist. And so he really has a remarkable skill set. So, but this shows the basic steps of SVC implantation, dilation of the lower part of the stent with the balloon to create some apposition against the lower atrial septal wall. I don't think we necessarily have to go through all of these slides there. And so one of the issues has been that the stent that's being used is a balloon expandable PTFE covered stent. And these are relatively new to the congenital space and are probably one of the, maybe the only FDA approved stent for congenital use. Most of the time we're using biliary stents off-label for a variety of purposes. But those stents, current FDA-approved stents, are in the order of about 6 centimeters long, and the telescoping from the SVC to get far enough down to create a complete seal can require a longer stent just because of stent foreshortening. So this group has had a collaboration with NewMed, who makes these stents, in order to get some longer stent sizes that are custom made. In addition, the 10 Zig stent has a much larger dilation capability than the 8 Zig stent to allow flaring up to about 32, 34 millimeters without severe foreshortening that would happen with the other stent. So this just describes their benefit of having the capability of having longer covered stents in this area. And one of the questions that might come up is, why not just use self-expanding endografts that you might use on the aortic side? That I think that they actually may have more radial force and may dilate over time to create pulmonary venous obstruction later on. And one of the techniques that this group used was to put a balloon into the right upper pulmonary vein to left atrial pathway, while they put the other stent in to sort of mold the a balloon expandable stent around the pulmonary venous pathway, which would not be possible with a self-expanding stent. So overall, their conclusions were that this is a possible strategy that can be used in a selected patient population of adults with sinus venosus ASD. Obviously, sternotomy and bypass surgery in some of these patients is not easy going, although admittedly that for the most part, this would be the first sternal entry for most of these patients. The big problem that needs to be avoided is inadvertent occlusion of the right upper pulmonary vein as it comes to the left atrium. And there are certain anatomic variants where the right veins may come to the lateral side of the superior vena cava or higher up, where this technique would not be as successful. And obviously the longer 10 Zig covered stents that you see there will allow more of these patients to undergo this procedure.
Great stuff. Again, forgive this naive question from somebody that doesn't deal with a congenital heart population or kids. The study was restricted to grown children and adults. I take it then that this complex congenital anomaly is one that you can survive well with into at least young adulthood, and you're not at special risk of having a very foreshortened lifespan because of that. Is that correct?
Yeah, that's a great question. The physiology of it is essentially like a large secundum atrial septal defect with left to right shunt to the right atrium. And so the overall potential morbidities in the future as it relates to atrial tachyarrhythmia or pulmonary hypertension apply to this population as well. But those are usually late findings, not so much early in life kind of issues. And typically patients with sinus venosus ASDs don't have intractable heart failure when they're young.
Terrific. Terrific.
Dennis,
That's great.
I was gonna say, this is one big stent for a small hole in the heart, and it serves definitely a certain population. But we've, from in my little knowledge also about congenital disease, we see a lot of downstream arrhythmias coming up. Do you anticipate this being something that Dr. Rosenthal and the team will teach us about in the coming years, and maybe we'll learn more about?
I think for sure. I mean, anytime that we have implantable hardware that's interacting with the myocardium and the atrium, we have to wonder about development of atrial arrhythmia over time. I think one thing that is reassuring is that our experience with secundum atrial septal defect devices, albeit not along the lateral wall of the atrial septum or of the atrium, and we have not seen emergence of significant atrial tachyarrhythmia from that population with implanted devices within the right atrium. But again, as you pointed out, this is a slightly different location and something that we would have to continue to look for in the future.
Great. So you're going to start using this, Dennis?
Yeah, it's an interesting technique. I actually have a patient who could use some of this, but this type of technique, I think that really it's a determination of how those right-sided pulmonary veins actually come in, so you don't create obstruction. Pulmonary vein obstruction, as you have dealt with for a long time, with left atrial isolation procedures, it's a potentially big problem, and it is for sure for us a huge problem in little babies who are born with pulmonary vein stenosis, and it's obviously something you want to avoid almost at all costs, especially if it's preventable.
Yeah,
Do you have
I
3D
suppose-
printing, Dennis, that can help you with this? Do you have access to that?
Sorry, what I didn't
3D
hear.
printing, is that something that's helpful
Yeah,
here?
we have 3D printing. I think one of the limitations of 3D printing is that typically most of the 3D print models are relatively inflexible or hard resin, and may not replicate the exact interaction of what a balloon expandable stent system might do to surrounding structures, but certainly can be used initially to at least to try to figure out stent length, to get some idea what kind of apposition you might have along the posterior wall, because there are some leaks around the bottom part of the stent that can occur and leave you with some residual shunt. Certainly not as much as what you started with, but the ideal situation would obviously be to completely eliminate left or right shunting.
Terrific. Well, thanks, Dennis. Thanks for covering that ground so well. I'm going to toss it over to Steve now. Steve, can you walk us through some of the new releases on adult work?
Glad to. So we are going to move now to the adult presentations from day 2. And the first of those is socioeconomic and geographic access to novel therapeutics, and analysis of growth in transcatheter aortic valve replacements. Creighton, can you address that with us, please? Take us through it.
Yeah, I thought this was a really interesting study on healthcare delivery and inequities and how it applies to our field in interventional cardiology. Specifically, they looked at the recent development of TAVR, which basically started in 2011, 2012. And they, as the slide shows, they sought to understand where new TAVR programs were established once TAVR was approved in late 2011. Where the patient population served by these new TAVR programs, and finally the rates of TAVR among the different patient populations. So you can show me the next slide here. So the findings were interesting, and I'm going to just quote a few numbers that aren't on the slide. Between 2012 and I think it was 2018, when most of the TAVR programs developed, there were 550 new TAVR programs that developed. And most of those TAVR, almost 98% of them were in metropolitan areas, so in cities. And 50% of those were in cities that already had TAVR programs. So a lot of Me Too programs where there were already programs operating. The hospitals that developed these TAVR programs compared to the hospitals that just stuck with surgical programs that treated AS patients. The hospitals that developed the TAVR programs tended to be wealthier, and they tended to have patients who were more privileged, i.e. they were less likely to be on Medicaid and less likely to be in socially distressed areas. And then when they looked at the delivery of TAVR into patients, again, they found a similar trend. Patients who received TAVR were again more socioeconomically advantaged, going along with where the TAVR programs developed. They were richer, the patients earned more money, they had a less chance of being on Medicaid, and they came from less quote unquote distressed areas. So it's interesting, and maybe you can show the next slide, this issue of organic growth of new services in our country and how it is panned out with TAVR. TAVR programs have grown. I think a lot of us think there's plenty of TAVR programs overall in the United States, but they seem to be concentrated in places where socioeconomic where the privileged socioeconomic groups are living and therefore receiving more of the TAVR, whereas the less privileged socioeconomic groups are being served more with TAVR alone programs. And the future directions I think are interesting of these authors. They want to look at race and see if it's more than just socioeconomic issues, but rather whether race and ethnicity also are playing a role. And they want to identify system and patient level barriers and access. And, clearly the development of TAVR programs in places geographically where more advantaged socioeconomic people live and lack of development in places where less socioeconomic advantaged people live is clearly an access issue. And finally, they want to consider and develop test solutions to address inequitable care. And I bet you, I have some ideas. I bet you other people in this panel have some ideas and how we could deal with this very complex issue. But I think it's an important one. We got a lot of TAVR programs. It seems like we should have enough TAVR for everybody, but there's a lot of people who are still being served by TAVR alone programs, and it's impacting the socioeconomically disadvantaged people.
Well, thank you. I think this is an important topic. There are lots of pieces to this, and we talked about that, whether it's system, whether it's payer, whether it's patient, whether it's location. I'd be interested in hearing thoughts from the group. I think we all have something to contribute into what we think is playing a role here. So,
to me, it almost feels like the same history of surgical or heart surgery, developed in the country, and the same initial distribution in the major, around major cities and wealthy communities, and then expanding to the rest of the country. So, maybe a little bit of regulation to help motivate hospitals or systems, and not just motivate, maybe support those systems to build TAVR programs to improve access to different populations.
So I think TAVR program is something that is different. A heart surgeon with, adequate nursing and anesthesia support as an N of 1 can expand that program out. I think, what are your thoughts about TAVR programs? As we've grown those are multidisciplinary. They involve surgeons. They involve, needs for bailout. What do you see in terms of system expansion? Do you foresee a time where a interventional cardiologist is going to be going to a small community hospital and doing TAVR, without the surgeon available, without that input? Is that something that we're at a point we're going to do, and will that help address the issue?
I mean, I don't actually see that as much as I do see that TAVR programs can expand as TAVR becomes safer and more routine. I see that there's other things we can do to address the equitable the availability of TAVR to all sorts of different Americans. And I think, personally, we have to recognize that I think aortic stenosis probably shouldn't be treated in a place that's TAVR alone. Maybe I'm biased, but I think TAVR should, and a multidisciplinary team should always consider how to best treat the aortic stenosis patient. And that's not going on. Apparently there's patients who are still being treated in places where there are no interventional cardiologists to evaluate these patients for TAVR. So that's, I think, the first important thing we have to say. Secondly, I think, maybe you need to bring TAVR centers to patients. Maybe you need to develop systems where you bring patients to TAVR centers. I mean, I think that's doable more than we like to admit. The healthcare field has not gone into transporting patients and providing accommodations for patients. But I think we all know people of means who do that all the time. People run to Mayo Clinic, Cleveland Clinic from Florida, from Washington, and they get their care. And I think that can be done on a much smaller scale for patients with lower socioeconomic, advantages.
Yeah, so I've been in two areas that deal extensively with that. San Antonio with South Texas, and now in Louisiana and the Northwest Corridor, all of which have, patients who are several hundred miles from us. We do outreach clinics and we do bring people in. So I agree with you. I think that there are ways for us in the same way that transplant patients now have regional clinics. Let me bring up the most difficult problem here. TAVR, even in really good centers, is it a money maker or a money loser in your hospital? Let me ask that question because that's important. And, in my experience, Medicaid won't pay for it because of those expenses. And so I think that we do have to deal with how we would fund, an initiative that would extend this out and who would be underwriting that.
Yeah, I think that's an important point, Steve. We're maturing in our TAVR work, and we're reaching that point now where we can say with confidence that for many patients, possibly most patients, TAVR is not just a good alternative, it's the superior alternative to open surgical care. So, Creighton, I agree with you. It seems a little unconscionable that a hospital center would offer only surgical services, unless there was some legitimate reason that they were unable to stand up a TAVR program. And that can happen. The access issue is a complex one in my mind, though. It's not just the geographic access, but we recognize that in American healthcare, the access barriers have little to do with distance in most cases. In my community, I have folks living 10 miles away from a very busy TAVR center, and we have to work diligently to create access for those folks because their socioeconomic situation simply puts up barriers for them that sometimes we don't even understand very well, even in today's environment. So I applaud this team for taking the painful look at our practice. I think it's difficult to look at those numbers and not conclude that we may have, or perhaps it would be safe to say we now have evidence that there is implicit bias in the way we perform invasive care in American healthcare systems. Painful, entirely believable for me. And now that we see it, I think we have an obligation to go after it. It's the sort of thing that SCAI does very well, by the way.
Yeah, and I think systems of care where, that care is extended to individuals more broadly than we're doing it is going to be part of this. So it's going to be great to see what they find. I'm sure there's going to be new information that we don't understand yet. But beyond that, as Kirk, as you say, I think it's incumbent upon us, once we recognize that, to begin to develop plans that encourage, enhance that access and improve care. If we're showing that we have a better outcome with TAVR, then it's upon us to make sure that that's available. So that was a great one to bring forward, and thank you. We're going to ask you to also compare a controversial area. Creighton, if you would, we want you to talk about comparison of ischemia trial population to patients undergoing percutaneous coronary interventions in U.S. practice. This is a CathPCI National Cardiovascular Data Registry Research to Practice Initiative.
Yeah, I don't know if this is done before, but I found this study to be interesting. They looked at how ischemia applies to the ongoing real-world PCI in the U.S. And specifically, they pointed out in their introduction that ischemia, unbeknownst to most people, excluded a lot of patients, even patients with stable ischemic heart disease. Obviously, it excluded acute coronary syndromes. I think everybody knows ischemia was a study of invasive versus conservative therapy in stable ischemic heart disease. So it excluded acute coronary syndromes, but it also excluded patients with EFs less than 35%, patients with significant left main disease, patients who had medically refractory angina, et cetera. Next slide. So the authors look at the NCDR database for about the 20 months before ischemia was published and presented. And they looked at all the PCIs performed in the NCDR database, which covers about 90% of the PCIs in the US. And they tried to look at how ischemia inclusion exclusion criteria fit in. Well, it turns out that 60% of PCIs performed during that period of time were actually ACS patients. So right away, most PCIs aren't covered by the ischemia data, and rather covered by a lot of other data that shows good benefit to intervention in terms of reducing major adverse cardiac events. The residual 40% of those million or so patients were stable ischemic heart disease patients, but maybe surprising to some, most of those stable ischemic heart disease patients also were not ischemia-like. In other words, they didn't fit the ischemia inclusion criteria. Either they were higher risk than ischemia allowed into their study, or they were lower risk. Only about 30% of the stable ischemic heart disease patients, or about 15%, I should say, of PCIs overall, performed right before ischemia was published, was ischemia applicable to. Now, 30% of the patients were not classifiable in the database. They couldn't really put them in to one category or another. So we got to recognize there's a limitation to the data. Maybe it's a bit more. Maybe it's more like 20% of patients getting PCIs were ischemia-like. Hard to know, but not many, a minority. Next slide. So with that in mind, we should also keep in mind that some centers, of course, treated a lot more ischemia-like patients with PCI than others. And here you see kind of the distribution over the number of facilities that we had. Next slide. And here you see the outcomes of these patients. Patients who were quote unquote ischemia-like had a very nice outcomes seen in the second to the left column, very low death rate of 0.11%. Patients who were higher risk than ischemia, seen in the leftmost column, had as you might guess, a higher death bleeding rate. And the patients who were not ischemia-like were pretty similar in terms of their outcomes. Because of their low risk, were pretty similar to the ischemia-like patients. But all that being said, next slide. I think, next slide. Well, we lost it. I think the interesting point is that, when ischemia came out, it was billed to the public and to maybe a lot of our general cardiology colleagues as a study which showed that conservative therapy was really as good as invasive therapy in terms of preventing future heart attacks in patients with stable ischemic heart disease. And I think what this study shows that actually in real world patients that we actually take care of, patients who meet the ischemia-like criteria are a small minority of the patients. And I think not included in the study is the fact that the patients included in ischemia were low risk. Not low risk by the amount of ischemia that they have on their nuclear tests. That turned out to be false. The amount of ischemia doesn't matter. They're low risk by their symptoms, which turned out, if you recall the ischemia data, that's the big predictor of outcomes. The amount of symptoms the patients have coming in. And ischemia dealt with low risk patients, and ultimately it was about 15% of the patients who come through your cath lab. And I think that's a message that needs to go out to our general cardiologists and to the public alike.
Well, thank you. That was a great review. I think it brings up many other questions beyond that. I would just, by comparison, point out that Courage, which came out around the time that I was SCAI president and resulted in a little bit of discussion, only about 8% of the patients actually would have been represented in a PCI group. So I think in some ways, the fact that this represents a much larger group is helpful. Yeah. But as you point out, it still doesn't mirror the majority of patients.
Right.
So what do you think about the fact that 1/3 of the patients in the NCR database weren't classifiable?
Well, that is also very interesting. It probably goes to the point that we could probably do better in data collection. I don't know how much effort we need to put into data collection, but I think it's definitely helpful for understanding what's going on through studies like this, and to make changes as we go along. So I think it's an issue of data collection and maybe how patients are being cared for, whether they're getting stress tests before their procedures. But that's definitely a big important point.
Yeah, I tend to look at studies like this and find them helpful mainly in the sort of tangential conversations we might have around a trial like ischemia. That is, somebody comes up to you and says, Creighton, what in the world are you doing? Why are you doing all these angioplasties? And the answer can be, I have a lot of patients that are high risk, stable patients who for whom I don't know what best to do because we don't have a trial to help inform that decision. So I'm left using what I have at my disposal. I know that they don't look low risk like the ischemia patients, so I'm not going to start with that. I'm going to look at everything and make a good conclusion about how to walk forward. I do worry a little bit that we can get distracted by a study like this and conflate that message that I just tried to summarize, my takeaway, with a different message about the ischemia findings and how they ought to be applied to the patients that did fit. So if you have an ischemia-like patient, I think this study underscores what we learned from ischemia. They are a low-risk population. You can manage them medically and not put them at grave risk. I think there is an important story left untold here about the future risk of spontaneous infarct. That's an important one.
Absolutely.
But I think there's no doubt that in the past, we've had patients that have had a little more pain, break through their meds, do a stress study, they've got a big patch of ischemia. You cath them, and if you find something, you're treating, because you don't want to get a call in the morning that your patient died in the middle of the night, right? It was a legitimate fear. And I think we've gotten wiser in our approach to these patients by virtue of trials like ischemia, which, although imperfect, I think stands on its merits. It was a well-done study, and I think we have to, as an interventional community, be honest about how that trial ought to inform our decision-making in 2021. I don't know, maybe the panel doesn't feel that way. I'd be interested in your opinion.
Louis?
Yeah, I was going to say, to your point, Kirk, I think what this study to me highlights is the importance of being careful about how to generalize on trial data. I think a lot of what came out of the ischemia trial was generalized to a lot of patient populations that were not part of the actual study, or were not part of the disease entity that was addressed in that study. As we communicate the data, we need to be careful as a society, whether it's interventional cardiologists or the general population, about how to generalize and interpret the data in the context of the disease that we're treating, and make it clear, what we're trying to send as a message.
I think the other thing I took away is how important it is for us individually at our centers to look at this same kind of information. Are we a center that doesn't treat ischemia-like patients? Are we part of that, group that does very little? Or are we a group that only treats ischemia-like patients? Not to use that as the reference necessarily, but I think it does tell us that we need to have a more robust quality assurance program at home and decide where we're at. Are we not filling in data we should? And so that's another message I think it shares with me about the NCDR and how it can inform us.
Right. And maybe, we'll soon learn also more about, plaque morphology and vulnerable plaque, and we'll be able to really make a distinction between those patients who truly have stable coronary disease and those who would benefit from PCI because their disease is unstable.
We hope so, and we keep looking for that tool, don't we?
Yes.
Those would be great information to have. We would love to be able to separate those out.
Hey, so in the meantime, Steve, before you move on, can I just ask the panel, what are you doing with cardiac CT these days? Did ischemia change your thinking about that? Does the availability of FFR now have an impact? I'm curious.
Great.
I can say it's been a catalyst for me. I mean, I think I recognized before ischemia came out the value of CT. It's incredibly helpful in many, many patients. We don't use FFR CT. We just don't have access to it at this point. But I find it very helpful to mostly reduce the number of coronary angiograms that we do that show essentially normal or non-obstructive disease. And I think it's been very useful. So.
The way I've been incorporating it into my practice, I think FFR portion actually adds a lot to the CT component because, it's a learning objective for us and the general cardiologist. It's mostly ordered by general cardiologists. And then the patients are, they contact us, do we need to cath this patient or not based on these findings? And the FFR portion does add quite a bit because of, I don't know if you've dealt with coronary CTs by themselves. They tend to show a lot of calcium, and that can be interpreted by the readers as obstruction, where in fact, in reality, it's non-obstructive. And it's still, in my opinion, it's still a moving target, and we're going to learn a lot in the future about how to interpret it. The addition of FFR is certainly a great one to help minimize the invasive testing done.
Yeah, our approach really bifurcates. We heavily use CT in our chest pain center. We have an expedited protocol, intermediate to low risk patients. Between 2 and 6 hours are going to a CT scan if they don't have any other evidence of problems. And we use that as an important discriminator in that group and decreasing those patients that end up with more normal scans. In the outpatient stable disease, we're using it more. We are using that group more with the FFR to try to better target and tailor our therapies. Okay, and well, Kirk, you haven't answered it. You posed the question, you got to contribute now.
I wish I had a good answer. I can tell you at our place, we've just recently acquired CT-FFR, so we're just getting our feet wet with it. But I have to say, so far, people like it. It provided you get a good quality study, then you have to have the right patient for that. But if you get a good quality study, as Lawai and Creighton both said, it's a great way to avoid taking low yield cath cases into the lab. You ventilate your space there so you have higher yield work going to that space. And interestingly, if you talk to people like Campbell Rogers, who's a principal now with HeartFlow, he'll tell you the data confirm that if you rely on a technology like that, it's true that your cath volume goes down with respect to those low yield cases that are going to be nothing more but a diagnostic cath and out. But your revascularization work actually goes up. And the reason for that is best explained by the imprecision of nuclear medicine techniques in identifying multivessel disease, the patients who we are most eager to offer revascularization if appropriate. So I'm pretty excited about it as a step in the right direction.
Yeah, and that low to intermediate risk people are the ones that the nuclear studies are the worst at. So, I think it's an important technology. I will say the other reason that I use the CT, it's a great teaching tool. People that have disease, but not severe obstructive disease, it's much easier for me to show them their heart and show them that disease and engage them in self-care. I think there's a second piece of that that's incredibly important if we utilize that as well.
That's a really good point.
You show them a blocked artery, they can see that that's narrowed down there. Well, let's move on and talk about the last study for this evening, which is safety and efficacy of the second generation robotic-assisted system for percutaneous coronary interventions. Final results of the multi-center precision GRX study. Louis, can you share that with us?
Yeah, thank you, Steve. Out of all the trials that came out of SCAI this year, this is one that I'm personally most excited about. Dr. Mahmood presented the trial on behalf of the registry. And, looking back on the last 30 days of our profession, we've had tremendous advances in stent technology, in the pharmacotherapy that we've been using, but little has changed in the actual technique that we do PCI, meaning we have an operator sitting or standing bedside, performing the procedure while wearing a heavy lead apron and being exposed to radiation. So this technology with robotic-assisted PCI answers to both risks as well as improved patient care. So we have a study here that not only improves patient care, but potentially also helps the interventionalist, which is not very often that we see in trials. The main occupational hazards that we talk about, and I'm sure we've all been exposed to, are things like orthopedic illnesses, from back injuries and those things, to radiation-associated injuries and risks of cancer, cataracts, and so forth. So in order to minimize that, the robotic-assisted technology was developed, and it allows the interventionalist to manipulate devices and advance and retract balloons, wires, guides, and other equipment in and out of the patient's coronary arteries while taking a step back, sitting down without a lead apron behind in a cockpit that is radiation shielded, so they're protected from radiation, and without the weight of the lead apron and all that risk that is associated with it. So it was a large multi-center trial, 20 centers across the world recruited for this study, and there was a single-arm observational study supported by CorePath and their GRX system. These are some of the sites that the high recruiting sites that enrolled in the study, and the majority of them here in the US. The patient population and the indications for PCI were nicely balanced. It included everything from heart failure and LV dysfunction to positive stress tests, all the way to the most acute patients of ACS and STEMI. As far as the lesions treated, they also covered pretty much all different sorts of lesions and types of lesions, all vessels and lesions. More than half of them were actually type C and B2. The study looked at two main things, which is clinical success and technical success. Clinical success being defined as being able to achieve TIMI-3 flow with less than 30% residual stenosis and without any major adverse events within hospital stay. Technical success being the ability to perform the PCI without having to abandon the robotic arm and go to manual. And as we see across the board, clinical success was extremely positive, with the range of 98% in all different lesion types, and technical success was also pretty high, averaging about 90% across all lesion types. As far as safety, the procedure was fairly safe and had little adverse events. As far as major adverse events, there was actually in-hospital MACE was 0. And as far as the technical aspect of things, they also had very low rates of inability to advance or cross or retrieve equipment. These are the different risk lesions in terms of clinical success. So, looking at everything from osteal lesions to CTOs, which that was an interesting part. Dr. Mahmood mentioned that the CTO component that was done was after crossing the lesion. So they would cross the lesion manually and then attach the robotic arm and perform the rest of the PCI with the robotic arm. And that also explains why, among all the lesions, which is, we know that CTOs are one of the toughest to achieve clinical and technical success with, this had the highest because of you're eliminating that portion of crossing, right? So that explains the high rate there. But across the board with all different lesions, the study showed excellent clinical and technical success. this is just the same data set. So in conclusion, the study showed that robotic-assisted PCI, even in lesions that are advanced lesions of type B and 2 and C, were feasible and with high clinical and technical success. This technology will enable the operators to perform PCI at a relatively high success rates without being exposed to a lot of the occupational hazards that we deal with, and primarily orthopedic risks and radiation-associated risks. And the future is really exciting. So as we build our telecommunication networks and improve that, I think we'll be able to hopefully in the future perform remote PCI, which will improve access to specialized cardiac care in areas that are remote and rural, but which otherwise would not have it. Technology has ways to go. Obviously, it's in the very initial phases of development. With the addition of things like over-the-wire platforms. That's one of the big limitations currently. Once we add that, we'll get to do more CTO work that needs that technology. Obviously, we can extend it to the peripheral world, which is a huge thing, and we can perform things like atherectomy. And then lastly, as the robotic cassette right now can only manipulate a single set of equipment, so things like bifurcation lesions are limited. However, with future iterations, they're working on addressing that, and maybe we'll be able to do bifurcation lesions that way too.
Well, thank you. I think that we perhaps are seeing our future. I wonder about your individual experiences. Do any of you use a robotic system or have had personal experience with it?
I've used it. We were actually at Einstein part of the trial, and I've, as a fellow, actually, as an interventional fellow, I had the privilege to perform many robotic PCIs with Dr. John George and Sean Janzer and others. And the technology, there's a learning curve, and it has its own limitations, but being able to do PCI while sitting behind, a computer basically and a console and not wearing the lead is just a tremendous feeling.
Wait, are you describing an electrophysiologist?
That's we're gonna catch up with them maybe.
Steve, this technology kind of reminds me of hypertension. It's one of those things that everybody looks at and says, yeah, controlling hypertension, that's a great idea. What a great opportunity. The problem is your return on investment might take a decade to realize, right? I mean, it's unlikely we're going to see strokes to fall off precipitously if we drop average systolic blood pressure by 10 points. And this seems like it's similar, right? I don't think there's any doubt that reducing operators' exposure to radiation and lead and, the strain of being upright and hunched over a table for hours, of course, that's going to pay out, but it's going to pay out over such a long scale. I'm wondering why maybe you're the only one who's had exposure to it at an organizational level. What's the secret sauce? How do you get the CFO to listen to the argument for acquiring a robot, which is it's a spendy bit of gear?
That's a great question. And I just started with my organization. We're talking about it, and I'm trying to figure out what that messaging is going to be. But one big one that I see, if as an organization, if you care about the longevity of your operators, that's going to be an important one. The other one is the marketing aspect. Believe it or not, if people like to hear robotics, we have a robotic CT surgery program, and that's a big hit among, and it's a referral reason for us. So maybe we can market, complete coronary, percutaneous and surgical robotic revascularization, and that might drive some referrals and interest from patients and the population. And then there is also to the technology, it's not just that, it does add precision. So if you've used the console, you can literally advance and retract by a millimeter. So if you've used things like IVUS to determine length, then you can exactly measure and position your stent to the millimeter in where you want it. So I'm seeing a good future. It's just going to take a while for it to move in that direction.
Given that precision, the one thing that I was surprised at was the only 80% success in osteal lesions, because I thought that was an area that a robotic process really ought to help with, right? We all struggle with that. Am I in too far, out too far? How do I go back and forth? And that seems to be something that, was a little, just a little disappointing in that.
Yeah, I think part of that would be the interaction of the guide and the catheter. So with the robotic arm, you can manipulate the guide, but the maneuvers, I think when we talk about guide maneuvers, we're talking about a little bit of a big maneuver compared to what you do with your hand. And also there is, a lot of osteal PCI is, two ways. You advance as you pull back and you pull back as you advance, and that makes it a little bit more challenging for the robotic arm in the current form. And I think maybe that's part of that.
Yeah, obviously something that they can will mature, that they'll get better at, and maybe have a differential motion opportunities. But
Right.
Exactly. It's still, I agree, gives us food for thought. Are we going to look at the day where like we're sitting here right now, we may be at the computer and moving the console, and maybe somebody will be a couple 100 miles away being taken care of.
Can't wait for the day I wake up for a STEMI and just turn to my desk and do it.
I've not personally had experience, but I can say that one of the tricks to getting this taken up is how the company rolls this out. I know of a couple centers around me where it's been purchased and it's sitting in the corner gathering dust. And when that happens, your administration becomes a lot less interested in shelling out the money. And so if there aren't hidden logistical issues with the robot that we're not hearing about, and I think the company needs to be very careful in picking champion sites where they're really going to run with it, because I think it's going to be a problem for me to get it here with 2 other sites where not too far from me, where it's well known that it's just gathering dust in the corner after an initial honeymoon period. So I don't want to be a rain on the parade, but we need to, maybe there's logistical things that I'm not aware of and how this is used. You might have insight to that, or maybe you just got to get the right people who are really going to champion it, like Shami Mahmood and maybe yourself.
Yeah. And one other thing is that this is not just, used by interventional cardiology. So maybe collaborating with your neurointerventionalist, that's another population that uses the technology. And, if you can share the room doing the robotic PCI, you can actually have enough volume and expertise and push the administrators to say, hey, listen, this is not just me. This is a bunch of other people here trying to use this technology.
Well, one thing, go ahead, Kurt.
I was going to say, I don't think there's any doubt that you have to have a physician champion.
Yeah,
and in a busy center, you need a team of physician champions. The kind of technology you have, this has to be your default approach, and you have to have a good reason not to use it, or the machine will end up collecting dust.
Well, and it's not just a physician. This really is team, right? You need your nurses and techs in the lab to be asking, if you're not using it, why aren't we using it on this case?
Yeah, very, very true.
Yeah.
So it's engagement across the entire team bench here. Well, Kirk, you want to bring us to a close?
Sure, Steve. I want to thank everybody for joining us tonight, and I want to, of course, extend a very deep expression of gratitude to our presenters and subject matter experts this afternoon. Thank you very much for your review and for your insight. To the audience, I'll remind you that today's presentation has covered the late-breaking clinical trials that were presented on days 2 and 3 of SCAI 2021 virtual scientific sessions. If you haven't seen the roundtable review of the trials presented on day one, you'll want to search for that. A very well done session by Doctors David Cox and Cindy Grimes, both also past presidents for SCAI. Remind you too that SCAI is, with a membership of more than 4,000 from 75 different countries, your home for all things interventional cardiology. We achieve our mission of saving and enhancing lives through many means, including extending the best in educational content to you. We hope that this roundtable has been helpful, and you'll tune in again next time. Have a great night.